So keep tweeting about this, and there will be a panel of judges who will. Yes, best question or the best tweet in the form of a Twitter that will be awarded as a tab. So first may I request Major General Professor Atul Kotwal, Executive Director, National Health System Resource Center, New Delhi, to please come on stage. Major General Atul Kotwal is a medical professional, public health researcher, administrator with significant contribution in the field of public health administration. Dr. Kotwal has been providing technical support to Government of India as Officer on Special Duty Public Health to the Planning Commission, now Niti Aayog, and has received numerous awards for his contribution. Now I would like to request Professor Dr. Parvez Ahmed Kaur, Director and ex-officio Secretary Government, J&K Institute of Medical Sciences, Sora, to please come on stage. Dr. Parvez is a scientist of international repute and an expert at International Federation on Aging Canada, and has been chief editor of the renowned medical journal Lung India. Now I would like to request Dr. Shashi Sudhan Sharma, Principal Government Medical College Jammu, to please come on stage. Dr. Shashi Sudhan is also holding the additional charge of Principal Government Medical College Rajuri, and she is by profession a microbiologist and also head of the department microbiology at GMC Jammu. Now I would like to request Dr. Ashfaq Bhatt, who is JET Director, Norway-India Partnership Initiative, New Delhi, to please come on stage. Dr. Ashfaq Bhatt, prior to this, has been working in the capacity as a senior maternal and child health technical advisor in the Ministry of Foreign Affairs, Royal Norwegian Embassy, New Delhi, and is an excellent expertise in the maternal and child health areas. Now I would like to request Dr. Ram Chad, who is the National Professional Officer for Maternal and Reproductive Health at WHO India, and he has rich experience in planning, implementation, and evaluation of maternal health program, and has been actively contributing at national level for different policy initiatives on maternal and newborn health. At last, now I would like to request our moderator, who will moderate the session, Dr. Mushtaq Ahmed Dar, State Program Manager, NIPI, to please come on stage. Dr. Mushtaq has been, prior to this, working as Divisional Nodal Officer and Program Manager Child Health from 2010 to 2018 in the NHM, and is also heading the NIPI team in J&K and has actively contributed in preparing the IMR action plan and situational analysis document. So what do you say?
To all panelists and the participants. Before starting just an icebreaker, this first session, I would like to just, for the audience, that the maternal and child health, the focus actually on the maternal and child health has not come with the launch of NHM. It has been long before, since the CSR program was launched, Safe Child Survival and Safe Motherhood program, which was launched in '92. Then in '97, that became the first phase of RCH, which continued up to 2005. And in 2005, RCH2 phase was launched, and in the same year, National Rural Health Mission was launched, and it became a part of the National Rural Health Mission in 2005. So since 2005, there is a, it was as in, existed as in RCH Flexiful in the NHM, but the focus has been since '92, and there have been lot of efforts and inputs from the Government of India side state government side, for RCH, in terms of HR, in terms of infrastructure, in terms of logistics, drugs, consumables, trainings to this program. But for the child health component, there have been, on one side there have been inputs, and there have been progress, and there have been outcomes, and the measurement of outcomes, which we can proudly say that if we just plot the gains in child health, there is a trend. Just for example, in 2009, our IMR was 45, and now it is 17. So there is a declining trend in IMR, and the similar trend in under 5 mortality, neonatal mortality, and early natal mortality. But unfortunately, in case of maternal component, there have been a similar inputs because the two components which are inseparable, but there have been no measurement for that, especially for our erstwhile state and the UT. So this was a felt need, and our worthy mission director, once he took over, and he just felt that why are not we measuring the MMR? Then he came to know that it is actually the SRS data for this. We need a huge denominator. It is not be done. So he tasked our team, NHM team, and also NIPI team that we want a situational analysis done. We want the audit of the maternal deaths which have happened for the last 5 to 6 years, and other program also inputs to be analyzed and give the outcomes. That's why we are here today. So this is a background for this document, and with this background, as a national and state team of NIPI has supported NHM in preparing the data, in analyzing the data and preparing the document. I would like to begin with Dr. Ashfaq. Although here I am going out of the protocol, but because of the need of the time, I would like to start with Dr. Ashfaq, who is representing NIPI at national level as Program Director, to give a brief introduction of this document and share the key findings of the analysis for the audience and for the panelists. Dr. Ashfaq, please.
Thank you, Dr. Mishra.
Hello. Thank you very much, Dr. Mushtaq, with the permission of the chair. I would like to highlight the situation analysis document that was for maternal health services that was released by Honorable Governor Sir and today. And this has been an outcome of the support that has been, or the trust that has been entrusted upon Norway-India Partnership Initiative by Mr. Yasin Chaudhary sir. He entrusted us this task as Dr. Mushtaq was deliberating on this part. So I'll try to, I don't have a PowerPoint as of now, but I'll try to highlight the key findings, and then we'll have discussions on what is the way forward. So situation analysis for maternal health services started off with, as Dr. Mushtaq was pointing out, that Jammu Kashmir has very reliable estimates of infant or child mortality. So you have IMR, you have NMR, you have ENMR and all those things. But for the state of Government of Jammu and Kashmir, the NHM Jammu Kashmir did not have reliable estimates of maternal deaths, because if you see the SRS data, that usually clubs Jammu Kashmir with other states. So the first task that was entrusted upon us was that how do we get the reliable estimates, the true estimates or the reliable estimates of maternal deaths for Jammu and Kashmir. So this was the first task that was given as part of our situation analysis. And then Mission Director Sir, Mr. Yasin Chaudhary also suggested that why don't you do a true estimation, or what is the quality of services that are being provided. what are the facilitators and the barriers for quality of healthcare services, since we will be going to the field, we will be doing the secondary data analysis and of all the data. So this was an added objective, but initially it started off with providing an estimation of maternal deaths. The situational analysis framework, which we thought of at that point of time after discussions, and this has been guided by NHM Jammu and Kashmir. We had co-creations of these whatever situation analysis that needed to be done. So we thought that maybe first objective is burden of maternal deaths. So we worked on that part. The socio-demographic variance. So how do we ensure the socio-demographic variance and get a true representation of the maternal deaths that is happening? And then what is the access and coverage of services that are being provided? What is the health system preparedness for delivering quality maternal health services? And also adding up, as today's initial inaugural also talked about the quality of care from the client perspective. For the beneficiary perspective, we also thought about doing in-depth interviews and doing qualitative interviews on that component. So the methodology that we adopted, I don't want to go into the methodology as such, but just for the sake of everybody, it was a mixed methodology. We did a secondary analysis of program and surveyed data that is already available with us. Facility assessment of 12 facilities in 8 districts was done. We also supplemented it with in-depth interviews, and just for the information, 5 medical colleges, 2 district hospitals and 5 CHCs were assessed as well. And the data sources, as I pointed it out, was from the SRS, was from the RHS, the Rural Health Statistics, the NFHS data, the PMSA data, and the FRU data that is already available with us. So if I come to the first objective was estimation of maternal deaths. So the predicament that we faced at that point of time was whether we calculate the maternal mortality ratio or the maternal mortality rate. So just for the sake, very quickly, maternal mortality ratio is if you see the denominator is 100,000 live births. For us to calculate on because this was the initial deliverable as per the report. For us to calculate the maternal mortality ratio, we, as you are all aware, the SRS data has a baseline sentinel surveillance sites, and the enumeration is done later on those enumerated sites. So we did not have, there was unavailability of 100,000 sentinel sites. So maternal mortality ratio was not possible. So what we did is shift towards the maternal mortality rate, which SRS data is also providing us. So we had the denominator of 15 to 49, the reproductive age group, and the added benefit that came, we could also calculate the lifetime risk in the reproductive age group of 15 to 49. So sharing the first deliverable that was tasked to us by the NHM Jammu and Kashmir. So we did an MDSR data analysis, and the maternal mortality rate was calculated for Jammu and Kashmir, which was 3.2 over a period of 6 years data that has been done, and which is definitely if you compare it with the national average, it is 7.1. And if we start comparing it with the recently released SRS, the maternal mortality rate has come down from 6.5. This is not part of the report, but I'm also adding up the recently. So it has come down from the Indian national average. The national average is 6.5, and Jammu Kashmir is 2.5. So this was the first thing that we kind of did an estimation. And the other component was that we also calculated the lifetime risk, which has come down from 0.11 to 0.8 for the period of 6 years the data was evaluated. So definitely in comparison to the national averages, there is a significant decline of maternal mortality. So we have an estimation of maternal mortality rates for Jammu and Kashmir. So Dr. Mushtaq and the chair, the first thing that came out was maternal mortality rates is 3.2 in comparison to the national, which is significantly lower than the national average. And then we also did the MDSR analysis, and I'm just highlighting the key points. What came out of the analysis very clearly that 35% of the dying women are primigravida, and the illiteracy, the 56%, more than 56% women are illiterate. The place of death, again, I wanted to highlight it for the panelists and the group members, that 1 out of 4 women is dying before they reach the facility. So that came out of the MDSR analysis. So 25%, more than 25% of women are dying before they are reaching facility. And if we calculate, 11% of them are in transit, are dying in transit, and 15% are dying at home. So this is for the panelists. And other analysis that we came out that 1 out of 2 reported maternal deaths can be prevented. The preventable causes of death, if we include all the preventable causes, this is around 56% maternal deaths are dying due to preventable causes, the PPH, APH, I don't need to go into that detail. And the other component that also came out very clearly was 39% of maternal deaths were labeled as others. So we have Dr. Ram as well here, and Ministry of Health and Family Welfare, Dr. Padmani and Dr. Siddhar sir is here as well. So there is a need to classify maybe the maternal deaths and think about the MDSR software as well. And the other component in terms of the maternal health services, the other finding that we came out was, this is done out of the data that is provided for the maternal deaths. More than half of the dying women have received less than 4 ANC. Or if we do it the other way, 46% have received 4 ANC or more, but are still dying. So this may be highlighting towards the quality of care. And if I remember, the last NFHS survey did an evaluation of the quality of ANC, and it came out to be 21% for, if I remember it right, for Jammu and Kashmir, it came out to be only 21%. 4 ANC or more is more than 85 or 90%, but the quality of ANC is an issue that we could look. And the other component that came out of the findings was that out of those dying after delivery, 80% of them did not receive postnatal care. So this is one thing, the postnatal care, and obviously 2/3 of the women are dying during PNC or in labor. In terms of infrastructure and resources, as per the rural health statistics, there has been a significant increase in functional health facilities between 2005 and the last rural health statistics. The human resources have also been increased at the PHC, CHC level, and the doctors and the specialist cadre. But again, I am taking you back to the point. Specialists the number of specialists are increasing. Still, our mothers are dying at facilities. So I would seek guidance from the overall panelists and the members in terms of what needs to be done. In terms of Lakshya certification, I think the data for that was already shared. I think that is a point that needs to be done. And in terms of the client feedback, the perception of care with regards to respectful maternity care, the provision of care for newborns and mothers, and availability of basic amenities, I think the evaluation that we did, it found out to be more than 80%, which is a very significant, which is very good. So these were the key findings, Dr. Mushtaq and the chair. I leave it at this point.
Thank you, Dr. Ashfaq, for summarizing the findings of the document. And now we will start the discussion. And the first, we will go to Major General Professor Atul Kotwal. Sir is representing NHSRC, which is the apex body for providing technical assistance to NHM Government of India. Sir, while analyzing the data of MDR for last 6 years, from 2014 to 19, 649 deaths have been reported in J&K in this period. It has been observed that 39% reported deaths have been recorded in other category, as Dr. Ashfaq also mentioned in his findings. And no specific cause of death has been mentioned or assigned to them. Meaning to say that even after 12 years of release of MDR guidebook by the MOHFW, which was also supported by, drafted by the NHSRC at the time of Padmanathan sir in 2009-10, still the process is not institutionalized. There are issues in reporting, in reviewing, and classification of cause of death. Sir, as an health system, strengthening expert one of your core areas of interest, we would like to know from your expertise, what are the reasons for MDSR not taking off in more or less in all of the other states also? How to strengthen it to make it robust and reliable tool for information for taking corrective measures to avoid the preventable maternal deaths. Sir, over to you.
Thank you, Dr. Dar. Thank you for this question. And first of all, again, personally, thanks to the NHM team and the dynamic Mr. Asim Chaudhary for organizing this and for DP for partnering. Why I'm mentioning this, for the dignity of this stage, where you mentioned the reason also for this, I think while now, looking at more and more packages of services, we're trying to implement those. Let's not forget the RMNCH. So that's I think the importance of this conclave also lies in that. I read with great interest the report you shared the earlier draft to me, and the first thing which I read was the MDSR data, mortality data, and that because somehow we've been involved in a lot of discussion right now, even for COVID mortality. You all would be aware it came in papers and all also still being discussed. The WHO modeling and our insisting that CRS system. And as a earlier as faculty and now being somewhat interested with the how deaths are captured in the country. I am not going to details of that CRS and SRS. SRS, as you all know, is got more than 8,800 points, and 81 lakh is the population, which is determined by the decadal census. So it is, right now it's a 2011 census, 21 census rather than take place, it may change. So their estimates again, there are challenges in that, but CRS is becoming more and more robust. We have 2.99 lakh points from where data is collected, and out of this 85% are now computerized, either the ORGI system or the state system, and the state system talks to ORGI through APIs. So we are strengthening CRS as such. So maternal mortality also will gradually, I think, over a few years will also the capture will be strengthened. But coming now to this question that about the the maternal death review. 2009-10 was the first time. 2017, the revised guidelines were issued because a lot of studies, came up, and even WHO also did an evaluation about this, and you already shared. My job is made easier because we already shared a lot of causes of the maternal death also, which is one of the reasons why MDSR is there. So I think we need to understand. I think all of you present here would be knowing the system क्या है. Form 1, Form 5, Form 3 community-based MDSR के लिए, Form 1 and Form 4 and Form 3 for the facility-based MDSR. और कितने hours में आपको वो करना है review. Verbal autopsy is another important issue. So first of all, how to strengthen it? I think to speak, there are two issues. Either we say that MDSR is required or not required. But now I must commend the state again. And as per the SRS, it is 77. It is classified in other, you mentioned the challenge, but even with your figures that you mentioned of maternal mortality rate as such, so the things are very promising. But this is the stage where things become difficult. इतना कम नंबर आने पे उसको और कम करने में पूरा हेल्थ सिस्टम अप्रोच चाहिए. उसमें अभी एक चीज पहले क्या है, जब whenever death rate is more, आप एक भी चीज सोची ठीक करेंगे, इमीडिएटली कुछ ना कुछ इम्पैक्ट हो जाएगा. जहां कम हो गया उसको और कम करने में. Similarly, if you see the infant mortality rate, the major part, it used to be 2/3 used to be neonatal. Now it is more than 75% of neonatal. So to reduce that, the challenges are more. Same with maternal mortality rate or whatever you are happy with. Though I have an issue with the maternal mortality definition as such, because world has two definitions of maternal mortality rate. Denominator में आपने all women ले लिए reproductive age group की, pregnancy. Developed world में वो possible है. they are taking in UK and all, they take maternal mortality rate as all those who are pregnant because they're capturing set percent. हमारे में नहीं है, that's why we use maternal mortality ratio. But yes, this rate is also better than that. So strengthen करने के लिए हमें पहले ये सिस्टम समझना है जो आप सबको आई थिंक सबको मालूम है, मैं उसको रिपीट नहीं करूंगा. तो उसको पहले स्ट्रेंथन करना है कि हमारे सब हेल्थ केयर वर्कर्स का कैपेसिटी बिल्डिंग है कि वो फॉर्म कैसे भरना है, कैसे करना है. वर्बल प्रॉक्सी जो कम्युनिटी बेस्ड के लिए है वो है कि नहीं. एंड एक्चुअली उससे भी पहले बिफोर दैट एक्सेप्टेंस ऑफ MDSR. Why MDSR did not take roots and even MDSR still now, which is a surveillance reporting and reviewing, is because as healthcare workers we also feel very threatened कि हमारा ही review हो रहा है. And why I'm mentioning it rightly, it should be mentioned here कि पहले वो था, there was a blame game sort of thing also. But 17 वाला guidelines are very clear. There is no blame game. No one has to be blamed. So उसमें we all health workers have to now accept it कि yes, we have to strengthen MDSR. जब तक हम नहीं इसको accept करेंगे तब तक इसको strengthen कोई नहीं कर सकता. Any kind of policies can be made. But so once we accept that yes, it is not fault finding, it is not victim, not saying it is not blaming, it is to understand and analyze and use that knowledge. So capacity building in the system, capacity building of understanding collecting the data, उसमें हो जाएगा. Capacity building for analyzing it properly, and not कि you leave it analysis. Analysis के बाद how will you utilize that knowledge to improve your either practices or infrastructure or care or diagnostics. तो जैसे 3 as per MDSR guidelines क्लियर लिखा है कि delays can be at 3 places. One is in decision making. उसमें socio-economic cultural factors हैं, but women empowerment is a major issue. And education, जो आपको भी इस रिपोर्ट में भी बताया. So that is a multi, intersectoral collaboration वाली बात हो गई. The Chief Secretary also mentioned this morning that other ministries, so health as it is, we have to involve the others. But from our side, IEC and BCC activities for everyone whenever we have contact with them, इसमें हमारा frontline workers का बहुत बड़ा रोल है. Coming now to the transport, delay in reaching. तो उसमें से already बताया 25% are before reaching the facility. So there, ambulance services हमने norms बनाए हैं ALS, BLS के. I think it's time to revise those to as per the geographical area and time to travel. We are saying 1 hour. I think we should now start gradually reduce to 30 minutes as we are getting more funding and our systems are becoming more and more better. 30 for MDSR improvement we have to see at the facility. We have to now go for LDR. Labor delivery recovery room concept instead of the labor room concept only. 16 to 17 hours one lady has to be on the same bed. 4 to 5 hours postpartum, 4 hours minimum. So you'll be able to reduce that MDSR. So, but to strengthen this, why I'm mentioning these reasons, how to improve it, which I think I'm covering some other topics also. Because if we don't know this, we won't know where to look for to have our MDSR. Because ये कारण हमें पता है कि कैसे हो रहा है. So इनको once we are able to capture these in our MDSR, discuss it in a very healthy manner professionally, we'll be able to look at reasons. There are some more issues which I noted down actually while reading that report. कि infrastructure, drugs, quality is again very important. लक्ष्य and cost. तो आप देखिए पूरे स्टेट में कितनी सुपर नोटिफाइड फैसिलिटीज हैं, कितने पे MCH wings हैं. I was very happy to see MCH wings also being shown here in the morning. कितने स्टेट नोडल ऑफिसर तो है, कितने डिस्ट्रिक्ट नोडल ऑफिसर्स नॉमिनेट हैं, और 20 डिस्ट्रिक्ट दे हैव स्टेट डिस्ट्रिक्ट नोडल ऑफिसर और नॉट. दीज आर द गवर्नेंस मैकेनिज्म. इनकी मीटिंग्स कितनी बार हो रही है साल में, उस मीटिंग्स में कितना क्या डिस्कशन होता है, कितने प्रोपोर्शन ऑफ केसेस रिव्यू होते हैं, एंड हाउ मच ऑफ दैट रिव्यू कम्स बैक इनटू द पॉलिसी लूप, and those whatever learnings are there are utilized to improve the system. So these are the issues which we need to take care of when we are thinking of improving the MDSR the surveillance system. Just quickly 1 or 2 more points. That identification of high risk pregnancy. इसमें again MDSR के लिए that is also important. The capacity building for that also. This thing confidential now with lower this thing. We have to have a concept of confidential MDSR wherever the states have a lower MMR. So yours is moderate, but is much lesser than the national average. So I think it's time states on the confidential MDSR also. So there, that will be immediate acceptance by the healthcare workers also, by everyone. And involve the district collectors for some proportion of review, which is part of the guidelines, but I don't know how much is done in J&K, but few other states where I have seen, personally, it is not being done. So there, I think that is also an important issue, how to strengthen the MBSR. I think I'll stop here. Maybe later on some other points will come to mind. Thank you very much.
Thank you, sir. Thank you very much for giving a detailed perspective that it is time to pull our socks and take MBSR seriously. So guidelines are already there. They are since 10, 12 years. So we have to take them seriously to prevent the preventable deaths which within the facility and those which are not reaching the facility. Thank you, sir, so much for enlightening us. And before going to the second panelist, I would like to request you all, please keep debating with hashtag J&K MCH Conclave regarding the feedback of this session. Thank you. Now we'll go to our second panelist, who is Professor Dr. Parvez Ahmed Kol, who is Director Schemes, Srinagar. As Dr. Kol is representing the premier postgraduate institution of J&K as director and is a renowned scientist of international repute, which we are very proud of. And also, recently he has conducted research on anemia prevalence in women of reproductive age in low and middle income countries from 2002 to 2018, which has been published in a leading international journal called Nature Medicine in October 2021. Sir, just for your, just to inform you, after analyzing the NFHS 5 data for 1921, anemia prevalence in J&K, it has been observed that the prevalence of anemia in all age groups between for men from 15 to 49 years has increased significantly, and it ranges from 65 to 79%, which was also mentioned by our worthy Chief Secretary. The concern was highlighted him also. So, and during the same time period, the uptake of iron folic acid tablets it has been also recorded has been only 30%. Sir, I would request you kindly share the findings of your research work and advise and guide the audience and policymakers regarding the strategies to tackle this public health challenge of huge importance in our segments. Over to you, sir.
Thank you, and thanks, Senator, for having me here and discussing this very important topic. Anemia, I mean, I've been asked to talk on that and discuss anemia. It is a globally widespread condition that we know affects causes an increase in the mortality, as well as does contribute a significant reduction in the economic production. So what we did is that and who did it first? The Institute of Health Metrics and Evaluation is a University of Washington division, which looks at the global burden of disease, and they look at the global epidemiology of disease world over. And we have published significant papers out of that. I am very fortunate to be a part of that GPT data. And based on what we did was that we geospatially mapped anemia prevalence from 2000 to 2018. And in this period, we looked at the various countries, there's 82 lower and lower middle income countries, and found out what is the prevalence of anemia in women of reproductive age from 15 to 49 years. What Dr. Mushtaq told me is more horrifying to me what we found during the course of our survey. And once we looked at, we know that, I mean, maps of comparative analysis estimates are very important, especially once you have them in terms of time and space, so that we are able to identify the problem, give it to the policy planners so that they can actually identify the targets that can be targeted for achieving our goals. So what we found at the end of the survey was that and we also have to understand that anemia is such a big problem that WHO has
now included as in October 2019 as an important goal for the SDG 2.2, and their aim is to reduce anemia by 2030, which was extended beyond 2025 subsequently, and by half. So that is a very important concern globally. So what we basically want to do is that we want to reduce the anemia in the women of reproductive age, that's 15 to 49 years, pregnant and non-pregnant, by half by 2030. What we found that about 500 million ladies, 449 million to be precise, in these lower and low middle income countries, constituting around 82 countries, did have anemia, which ranged from mild to moderate to severe. And about 16 million of them had a severe anemia, defined as something less than 7 in pregnant and less than 8 in non-pregnant females. So there was a huge burden of anemia in women of women of reproductive age group. And if you look at the global burden, 30% of women in 2019 in the reproductive age group had anemia. That's whopping. Talk of the countries that have had the highest burden, only few countries. If you talk of Gambia, Yemen, Mali, Senegal, and India, the prevalence of anemia in this age group is to the tune of around 50%. There are only few countries, maybe in the Central American region or East Asia and in the Andean South American area, where the prevalence of anemia is not that alarming. It's between 8 to 10%. So it's a huge problem and needs addressing. And how do we address it? Addressing is by improved diet and fortification. It's very important to understand that normally we feel that if we increase our diet and our RDA or iron is going to be taken care of. Probably not. If we take a portion of meat, which will be around 80 grams, it will give around 2.6 grams of iron. If you take an egg, which is regarded as another source of iron, it gives around 0.6 grams of iron. If you take a bowl of spinach, it gives you 0.8 grams of iron. So even if you take all the three together, it gives you around 22% of required dietary allowance every day. So what do you need to do? You need to have what Dr. Mustafa was talking about, fortification of diets, of whatever, be it fortified flour, be it fortified whatever. Or even in pregnancy, especially once they come to antenatal clinics, they have to be given iron and folic acid supplementation. So that, and then mass deworming is another concept that is especially true in areas where you have a high prevalence of those elements, those phagocytosis that cause iron deficiency because of the continuous bleeding that they cause because of infestation in the intestines. So mass deworming, iron supplementation, and recognition that it is a big problem. And as Verdicius in the morning said, that anemia has got to be taken care of. It's a big problem, not only in the mothers, but the whole reproductive age group of 15 to 49, and it has got to be addressed. Whatever means we take here to do that. And COVID has actually exacerbated the food disproportion, and the worst hit have been women and children. There is an inequality in domestic use of food also, and women try to eat less compared to others in the family. So that inequality has to go. There is inequality in anemia, even on the global scale and even on the subnational scale. And we have to take immediate measures so that we can stem and hope that we can actually achieve the SDG goals. That is the global nutrition target of the WHO, that you reduce the anemia level by 2030 by half. And if we go at the current pace, only 2 districts in the country are going to achieve that. And if you look at the countries, the only countries that are in the lower and lower middle income countries, it would be China, Iran, Peru, that will be able to do that. Otherwise, we are in a very, very bad state, and we need to take a full cognizance of it and address it as quickly as we can.
Thank you, sir. Thank you very much, sir, for your valuable advice and sharing the findings of your research, which more or less corroborating with the data and FHS data. And as all of us are here and would like to take your advice so far, we have to take the diet seriously. We have to improve our diet. We have to focus on the fortification, use fortification foods, and iron supplements, which are present free of cost at all of our health facilities, and mass deworming. Thank you, sir. Thank you so much for your inputs. Once again, I would like to reinforce, please keep tweeting with using the hashtag J&K MCH Conclave regarding the feedback of the session. Thank you. Now we will go to our other esteemed panelist, who is representing the Apex institution in Jammu division, a tertiary care institution, Dr. Shishi Sudan, and she is also holding additional charge of the principal Government Medical College Rajouri, in addition to Government Medical College Jammu. Ma'am, out of 649 maternal deaths reported and which have been analyzed in J&K, maximum deaths, that is 79, which is about 12% of total deaths which has happened in J&K in the 6 years, are reported from Jammu district. Being the head of the main tertiary care institution, we would like to know from your experience and your inputs, what could be the reason for this high number of maternal deaths in Jammu and how to address this issue in future. Over to you, ma'am.
I would say it's a great afternoon in terms of we are celebrating mothers, motherhood, and we are looking forward to stronger families, communities, and nations. The things are very physiological actually, mothers, childbirth, delivery, things like that. But physiological perspectives have become pathological over some time. Population overgrowth, too much interference, ecosystem disturbed. That is my observations. 3rd of June, 6 p.m. from GMC Jammu, I started my journey on road towards Rajouri, and I got so many answers to these questions. I was observing around, not illiterate, but simple, ignorant, unaware, malnourished, maybe compromised nutrition and hygiene. These are the reasons for making simple things complicated and such bad outcomes. Particularly today only that J&K MCH was inaugurated and the need has been realized. This terrain from Rajouri again, 5 hours run on car from GMC Jammu to Rajouri, and then to make it to this venue, another about 8-9 hours, motorable, difficult, hilly terrain, and again I got all the answers to the questions. GMC Jammu is in the Jammu district, and maximum deaths have been reported in Jammu district only. That we hope we have the only tertiary care center, the public hospital of the Jammu region of UT of Jammu and Kashmir in Jammu, and all the referrals from all these difficult terrains, far-flung areas, and Jammu region particularly, I would say, vegetarianism is predominant, that is the lifestyle, and compromised hygiene, I would say, so many worms, unhygienic conditions. So there are simple solutions to these difficult encounters that we are encountering, that is good nutrition and iron, folic acid and deworming, as Dr. Parvez Gol said. These would rectify so much. Then monitoring the pregnancies, no antenatal checkups, home deliveries. So many die during transits. If 16% deaths are at homes, less institutional deliveries. So these awarenesses, they need to reach the masses. I think the way our Chief Secretary said, Social Welfare Department, school education, these things have to be to begin right there, so that the basic things like malnourishment, hygiene, these are the contributing factors towards high maternal mortality and even the infant and the, other mortalities. So simple solutions to things which look have started looking more difficult, but we have taken care of so many things. A tertiary care institution on one side and the developing new GMCs on the other hand. We have realized the scarcity of manpower. Another very grave area of concern is why more cesareans, because the healthcare professionals to monitor the deliveries, the labor process, they too are less. Also observations are that elderly primary gravida people go for these reproductive experiences late in life, maternal apprehensions. So two big areas I think equally important is we have to decrease the number of cesareans and we have to strengthen by awareness, that is, and the availability of ambulances here in UT of J&K that have made a huge difference. Referrals have decreased, periphery is being strengthened, especially the new medical colleges, and with that there is a progressive decline in maternal mortality, which is very obvious. Thank you very much.
Thank you, ma'am. Thank you, ma'am. Thank you for highlighting the reasons and the possible solutions. And we hope with strengthening of the peripheral health system and strengthening the referral transport system, and which is already in progress, a work in progress, as with the many new GMCs are coming up in the Jammu region, and we hope this issue will be addressed. And in new survey data coming, it will be among the lowest. Thank you, ma'am. And before going to another panelist, once again I would like to remind you, keep tweeting with our hashtag J&K MCH and Conclave regarding the feedback of the sessions. Thank you. We are having with us from WHO, National Professional Officer, Dr. Ram Chahar, and he has been providing the technical support at national level in maternal and reproductive health for policy-related decisions. Sir, the analysis of maternal death data, MDSR, shows for the last 6 years, which we have compiled in the document, that main causes of death, which are around 46%, are related to hemorrhage, PPH, APH, etc., and related to pregnancy-induced hypertension associated complications like eclampsia, preeclampsia, and other associated complications. Both of them are preventable causes. And it has been also observed in the report that 74% of the cases of death has happened within the institutions. So, I would like to know from your experiences, sir, what could be the reason that we are not able to prevent such preventable maternal deaths even after the mother is already with us in the health facility? And what course corrections are needed to address this issue? And I would like to, for the audience and other panelists, WHO has helped is helping the Ministry of Health in rolling out and has already rolled out the MDSR software. Sir, over to you.
Thank you so much, Chair, for first inviting me for this meeting and also for this opportunity to witness the transformative change that the NHM and the State Department of Health in Jammu and Kashmir and the partners are bringing about. My compliments from the WHO Country Office for the great work that the state has achieved in terms of improvements in the indicators and the progressive and the impressive gains that we have all witnessed in the MCH scenario in the state. Coming to the question that Dr. Dar has put up, it's a very interesting situation that we have 74% of the deaths reported being in-facility death or the institutionalized deaths, and amongst the total deaths that have been reviewed, we have around 46% that are contributed by direct obstetric causes of maternal death, which mainly includes the hemorrhagic conditions as well as hypertensive disorders of newborn, hypertensive disorders of pregnancy. So it's a very ironical situation that the mothers are in the hospitals. Despite that, they are dying. So just to begin the discussions or my observations on that, I would start the point with a simple introduction of how the obstetric transition works. This is something that we have been using a lot in the recent times in the country, and it is similar to the way demographic transition happens in any country. To begin with, any country or any health system has very high fertility rates and we have very high mortality rates. So both of them are balancing out each other. Over the course of time, as the fertility rates reduce, we see a gradual reduction in the maternal deaths as well. So those are the times when there is a need to focus upon bringing more of the institutional births, increasing the coverage of essential interventions. The stage 3 is the stage where we have sort of reductions in the maternal deaths, but they are not keeping up with the way the birth rate or the fertility rates reduced in any particular health systems. Notably, this is the stage in which most of the states in the country are, and this is what even the state of Jammu Kashmir is currently going through. So what are the things that define the stage 3? Fertility is variable. Direct causes of maternal mortality are still predominating and are the major factors that define how the maternal deaths are happening in the health system. It's a complex stage and requires interventions both in terms of improving the quality of care, improving the skilled birth attendance at birth, which brings about implementation of evidence-based practices, and also ensuring appropriate management of emergency obstetric care. So, if we have essential early interventions which we know are meant or which are proven to improve the way, if they are implemented, can bring about reductions in the maternal and newborn mortality, that would be the first requirement for the state. And the Lancet Commission had highlighted that implementation of high quality evidence-based interventions can bring about up to 58% reductions in newborn and childhood mortality as well as the maternal mortality as well. So the intervention that we need to focus upon, and I'm sure that the state has already started the work on that, is improving the coverage of skilled birth attendance at birth and ensuring high quality coverage for emergency obstetric care. This is sort of, we could say, manifested in the way we have seen increase in the number of new obstetric units that have been operationalized across the state, and I'm sure that in the next iteration of the MDR that the state undertakes, we would see an appreciable reductions in the direct obstetric causes of maternal death in the total maternal deaths that the state will have. The second point that I would like to highlight is this is related to the point where we have around 34% of the maternal deaths are contributed by primary gravidity. So this is a sort of indication of that we are losing out the primary first-time pregnant mothers in the total contribution of the maternal deaths, which needs to be worked upon. This is reflective of gaps in the antenatal care services that we are providing. There is an increase in the HRP identification identification from 5 to 13%, but I think we can do much better. The coverage and the number of visits, the number of contacts that our pregnant women are having in the last trimester will definitely help us in improving our high risk identification as well as in bringing about a reduction in the complicated pregnancies. The third point that I would like to highlight is that, and Dr. Professor Kotwal has also mentioned about it, is the role of having a well-functioning MDR system. The MDR as a system is geared towards not only helping a health system understand what went wrong in a particular death, helping us investigate the causes as well as the circumstances that happened that leading to the maternal death. There are 4 steps. The first is the identification, the second is the reporting, third is review, and fourth is response. Once we start having a very robust system that helps us in identify each and every maternal death, we can have a follow-up actions for all the rest of the steps. And as our maternal death rate keeps on reducing, this will become difficult and difficult. And I'm telling you, the more robust our MDR system is, the better functioning of our health systems we can take a guarantee of. If we have a well-functioning system that helps us in understanding the causes of death, we can have the response, and having a response in the form of well-functioning QI committee both at the facility level, at the district level, and at the state level that takes the recommendations in place and also helps the institutes in developing the way forward from each and every maternal death that is reported. Making it an integral part of the established quality of care improvement plans would be the way forward for the state. That's all from my side. I hope that has been quite helpful for the discussions in this panel.
Thank you, sir. Thank you for your valuable inputs. And as sir has also suggested that we need to increase our skill birth attendance coverage, means by training more and more of staff nurses in SPA training or Dakshta training, and we need to take care, improve our labor rooms and operational theatres. The way forward is the Lakshya certification, which takes care of labor rooms and maternal OTs, and of course the strengthening the MDSR. Thank you, sir. Thank you very much for your valuable inputs. And before going for the final comments from our panelists, esteemed panelists, I would again request you please keep debating with using the hashtag J&K MCH Conclave. Sir, now as we are coming closer to the time limit which have been, the time slot we have been allotted, I would like just a brief final comments from each of our panelists, starting from our Kotwal sir, Major General Kotwal sir, if you would like to highlight or respond any of the things which have come out during the discussion. Over to you, sir.
Thank you, Dr. Bhatt. Thank you. In fact, I was waiting, just left a few points unsaid. I thought probably there might be some tweet or some question from the audience. So I think nothing has been received. So I think for MDSR, leveraging technology, that I think one of the way forward, in addition to, of course, first acceptance by all of us, that I already mentioned earlier. Some innovations. The NIPI is also here. We should, think of some out-of-box innovations also, how to strengthen it further while leveraging technology. Similarly, some kind of study, once you have already done this one, now you could also do that the proportions which are reviewed, what is the quality of the review, what has been synthesized in that, and what kind of learnings have been there, and what is the utilization of those learnings. So that small study situation analysis could be probably done in J&K and also probably some other states too. So we can discuss it further also later on. So that will also help us, in strengthening the MDSR further and telling people with as a proof of concept, see, this is the what. When you review more and more and you utilize those to improve the system improves. And of course, I would like to mention here that another thing which I thought probably is going to be more interactive, but I think time is short. The 3 things which I mentioned, which MDSR document also mentioned, I think we need to amend that also and add the 4th dimension of that is the pre-pregnancy. that is a life cycle approach which we are mentioning, which Dr. Paul also mentioned. The anemia is linked with hemorrhage as such. So that also I think we need to now link with in our when we are doing MDSR review, we need to look at that component also. Otherwise, we are forgetting that during a review. So the another is classification, as you very rightly mentioned. Even the cardiac cause, which is brought up in your report and also in many other reports, those also could be either hypovolemic shock or septic shock. So it's either hemorrhage or it's infection. So there again, quality becomes very important. Or of course, there will be some proportion, very small, which will be microemboli and this thing. Those are of course different thing altogether, but majority would be those. But I think I'll stop here. But thank you very much. Listening to all the other panelists.
Thank you, sir. Thank you very much for your inputs. Now we will go to Professor Parvez sir for his final comments, please.
Okay, I will again restrict myself to anemia, and if I talk of one parameter and say that unacceptable levels of anemia in any society is more than 5% in an administrative unit, say a district in our place. 98.9% of districts in lower and lower middle income countries have this unacceptable rate of anemia in the women of reproductive age group. And have we done well? We have, from 2000 to 2018, we mapped it. The rates were 35% in 2000 and 31% in 2018. We have moved, but very sluggishly. We need to move fast in order to achieve what WHO has tasked us to do. Thank you.
Thank you, sir, for reiterating your appeal to eradicate or eliminate this public health challenge, as has been set the target for this. Now, we would like to go to Madam Sudan, Principal GMC, for her final comments.
Well, I would like to summarize it as the awareness right from the schools, involvement of social welfare departments, right from there, the principles of hygiene and nutrition, very important as a microbiologist. AIDS sepsis, equally important, and closer monitoring of pregnancies, more antenatal checkups, that awareness again is to institutionalize the maternal care and child health both, and institutional keywords and reduction finally in number of cesareans, and maybe a step towards painless deliveries, that those trends in Maharashtra also and other Western world, and we revert towards nature and take help of nature and strengthen our system.
Thank you, ma'am, for highlighting the need for convergence and the need for giving a natural birth, sort of a midwifery approach, and strengthening of the peripheral institutions to decrease or eliminate the preventable maternal death. Thank you, ma'am. Now, I'll go to Dr. Ashfaq Bhatt, who is basically the son of the soil and has worked in various organizations. Before joining the India Partnership Institute, he has been in WHO also, for his final comments.
Definitely, thank you, Dr. Mustaq. We work very closely with National Health Mission in terms of identification of the key recommendations that have been provided. I think the findings are that would require some sort of a collective approach in terms of the health system, the out-of-box thinking approach in terms of identification of high-risk pregnancies and how do we strengthen the MDSR system, and tackle the issue of anemia, I think, which is grabbing the country for long. I think the health system approach of how do we, if I have to tick off, I would say for example, if I have to prioritize, I would say
74% are going in deliveries at dying at facilities. How do I ensure? Maybe I'm just thinking it at this point of time. Maybe the specialists are overburdened at facilities, and they may not be providing the quality, and then reflecting on the quality of EMC that needs to be strengthened. I would say that these are the two things that I would say would focus on. And we'll take the recommendations and work with National Health Mission in terms of defining the roadmap for obviously, as sir is pointing it out, that whatever situation analysis you do, we have to come up with plans of improvement and focusing on that plan. We work very closely with the state on that part.
Thank you, Dr. Ashfaq, for reiterating your commitment for strengthening the national health programs and working closely with NHM at national and state level. Thank you, sir. Now, last, we have with us Dr. Chahar. I would like to request him to give his final comments. Over to you, sir.
So the final comments, we are moving in the right direction. The pace of the movement is very good, impressive. What we need to be cognizant about is whatever gets measured gets monitored. So we need to have the systems in place, we need to have the system's capacity to monitor the data, analyze the data, and act upon the data. MDR systems, I'm very happy to see the state has taken the lead to analyze the reports and come up with the recommendations as well as the findings. But at the district level, the district should also have the capacity to monitor their own data, whatever the programmatic data is coming in from the systems. Identify what are the loopholes, what the data is speaking about, identify why the data quality is important, and take local actions. The approach that needs to be taken up is that the states, rather than state telling the districts what needs to be done, districts should identify from the data what they need to prioritize and act upon. So if the districts are able to work upon the MDR, the quality of MDR systems will improve, the accountability will improve, and we will have a well-functioning health system that is able to take care of the health of the mother and newborns in the hospitals. Thanks.
Thank you, sir. Thank you, sir, for your inputs. So we have reached to the time limit allotted to this session. And before closing this session, I would like to, once again, I would like to thank our esteemed... yes.
We have 3 questions, maximum of 3 questions. We can take questions if anybody has.
Yes, sir, please. Dr. John.
Yeah, I'm Dr. Muzaffar, actually, J&K Srinagar. Imagine a situation where a pregnant lady who is a plus in the previous starts building the primary care setup. She is referred to as secondary care. From there she comes to tertiary care. I have seen my ops colleagues very frequently say, what could we do? She came with 0 hemoglobin or 1 hemoglobin. She came with ruptured uterus. She came with obstetric labor, baby's labor was out, baby was dead. No, this is because of our secondary levels. We have, if we want to improve our maternal mortality, we have to strengthen our territories. We have no medical colleges come up, but still we are not seeing results. And now with these ICU centers, I think this ICU will only work when you have skilled manpower available to run these ICUs.
Thank you. Thank you, sir.
Any question?
Yeah, ma'am. Mike, please.
And introduce yourself, please.
I am Dr. Masuma Rizvi, Professor of OBGYN in Srinagar. We have not done a proper gap analysis for the people who are working at the grassroots. People who are working at the districts, the difficulties that they are facing there in bringing down this maternal mortality. Anemia, yes, it is one of the main causes which leads to enhancement of the obstetrical family. But what we face, the challenges that we face is identifying the problem, then having the proper referral system, and referring in time. We attach the ambu when they shifted the patient to our facility. So we received the patient with 0 pulse, 0 PP. So what we need to do is training and retraining and manpower, which is more important than the infrastructure that we are building across J&K.
A very good question from ma'am. Actually, ma'am, we had another panelist from Ministry of Health, Neha madam, and we had kept this question. This thing was for her, and I would like to read it out. And we have a representative from NHSRC, heading the NHSRC, and he will. I hope he will respond to this because they are also looking after the HR part of they are helping the ministry in HR. I have recorded this from the document only. The RHS data shows that there has been manifold increase in human resource for health, like specialist medical officers, staff nurses from 2005 to 2020, and during the same period, the number of health facilities, that is sub-centers, PHCs, CHCs, and medical colleges increased manifold. But during the field visits for collecting the primary data from 12 identified institutions of various levels, the providers have, there was a complaint, which I recorded, main complaint was the huge workload, which you have also highlighted, the huge workload and shortage of staff, and of course the training issues. Patients, the huge footfall in the public health facility, which has increased in the J&K, is also corroborated by the NHS-5 data, which shows that there are 92% of institutional births, 80% of our ANC coverage, 85% PNC coverage, 92% full immunization coverage in J&K. So in addition, J&K is a unique state in the country, sir, where more than 95% of IPD care is being provided by public health facilities due to less presence of private sector. So being health system strengthening experts and you are guiding the ministry, and Madam has also highlighted these issues, how to address this issue of huge gap in demand and supply and provision of quality services in terms of matching HR at high case load facilities at least. Do we need to think out of box, sir, beyond these IPHS norms and other norms which the Government of India has set or the state government has set?
May I make a small comment?
Okay, thank you, Dr. Dar. Thank you for this question and thank you for the comment also earlier. That's all related to this almost only. And Dr. Neha is also here. In fact, we were discussing it during tea also. First of all, I must comment that J&K is one of the few states which has, sanctioned posts which are more. Otherwise, generally, sanctioned posts are also very little in many other states. And so that means the intent is there. It hasn't when the HR are there available. And the state also has a specialist cadre, which is again very few states have done this. You have shortages in few the MO there is no shortage, there are shortages in few. And but then how to strengthen this further? If you recollect what all was presented, that how many HDUs and ICUs are now being created. Earlier, even if you had recruited these specialists and HR, suitable to those facilities, which are now being converted as FRUs, who would have worked there? No people would have joined. So it takes time. You have the positions already sanctioned, you have the infrastructure which is already there, and you have the medical colleges. Of course, these medical colleges, to get people trained from this, will take some time. So it is time that NHM flexibility is to be utilized. The NHM has a flexibility of even you quote we pay for getting specialists. Even those who have studied here and gone to other states or they will come back. Sikkim has been able to do this. Similarly, for all the other cadres too. And very rightly said that the number of FRUs, of course, has to increase, and that will be possible only when you have the concerned the requisite specialists over there, trained the requisite specialists. So and the time to travel, the travel time to the facility that I mentioned earlier also. And even in NDSR, I did not talk about involving the private sector and the regulatory mechanism, because the state as it is has majority of the things happening in the private sector and public sector, which is very, very heartening to see that people have faith in the system. So I think you are very right in your comments, but the planning is already there. Posts have been sanctioned, which are much more than the required. If you see that, I can share a table also with you which we prepared. And as again the sanction, as and when now the flexibilities of NHM has to be utilized once the infrastructure is in place, because you couldn't have got people without the infrastructure. And even the ambulance services again, the number of ambulances increasing gradually. So this thing will come up, but it is taking time. And once these FRUs are there, you won't get such cases of placenta previa or bleeding this thing and all, reaching the tertiary care facilities without getting the support from the FRU. I hope I have tried to answer the question. Thank you.
Thank you. Yeah. Please.
My submission is regarding the high-risk pregnancies, hemorrhages, hypertension, other miscellaneous high-risk factors. Shortlisting all of them and just have a list of clinical alerts to guide us when to refer, timely referrals to the referral institutions so that we are not late. Most of the time the patients report very late, although they are primarily and secondarily well managed or for required and desired tertiary care, they reach late. On that, we think we should have that system of trainings, retrainings, ongoing system in place so that we keep improving.
Thank you, ma'am. Thank you, ma'am, for your inputs. Now, I think it is time to close the session, and I once again thank all of our esteemed panelists for their valuable inputs, for their guidance, for their insight they provided us. And I'll also thank all the participants who are with us in this session for their time and patience. Indeed, it is a very proud moment for me to be part of such a panel, which having eminent people who are world, not only nationally, but they are world. Their contribution has been recognized throughout the world. Thank you, sir, all. Thank you so much.
I thank all the panelists for their insights and interesting talk on overall scenario of maternal health. I would like to request our panelists to please stay on the stage, and I request our working mission director to please hand over the mementos to each of our panelists. After this session, we will break for the lunch, and in the evening we have a ferry ride and also the cultural event. So I request our participants to stay back so that you can enjoy the cultural event in the evening. Thank you, sir. And the best tweet for this session goes to Ishan Farooq. Is anyone sitting there? Ishan. Okay, you will select your tab in the evening. The tweet is, can't solve all the maternal health challenges all alone by myself. Need and want others to join me. Hashtag join hands to challenge the challenges of maternal health. Thank you very much. We will break for lunch.
Everyone, please note before leaving, there is a very awesome ferry ride across the Dal Lake being planned for you all. That will happen around 5:30 p.m. onwards. But before that, we have 3 sessions to cover, and we'll be able to do that only if you all cooperate and we get over with. So please have your lunch in 45 minutes and get back by 3 and for the next session. And please stay till the evening, the ferry ride, and then of course the cultural program. We have very talented musicians performing on the banks of the river. Thank you.